Right. You'll be pleased to know I'm not going to talk about on pump and off pump. In fact, after the presentation of David's, I suppose you can take any stand you like. And this is the problem often with surgical evidence. I would like to give you perhaps the view of somebody who's been around now. Why practice are established, why people choose something rather than others. 1987, I sent some questionnaire to all the surgeons who was practicing at that time coronary surgery. There were only 80 in the whole of the UK, 62 replied, and 73% said, yes, I will use the mammary. So there was already more than a quarter of people who thought that the mammary was not really a very good idea. And contraindications were like age, the flow is not good through the mammary, and endoarterectomies. 5 years later, one of my registrars, by that time I was a consultant, repeat this. There were now 120 consultants. We were doing a lot more operation, and you'll be interested to see how the number of operations was much higher than what many of us do nowadays. On average, was more than 200. And the number of people who were now starting to believe in the mammary had gone up from 73 to 93%. However, there were still a lot of contraindication, which nowadays you would regard as complete nonsense. And this was 1992, when the mammary has been used. There have been all sorts of articles, including the famous Loop article in the New England Journal of Medicine and so forth. So there was still a significant reticent to embrace something new. Now, why is this? Often is lack of evidence. Now, this picture is from a famous Italian opera, I Pagliacci, but he was actually the editor of The Lancet, then a few years ago suggested that surgical research is really a comic opera. And I tend to agree with that, because we are not very good at doing proper study. And of course, then you get into the area of what interpretation you give to a study. You can almost come up with any answer you want. And the things which is never, unfortunately, taken into consideration, and this is coming from somebody who recently had a couple of bouts of surgery. I was on the wrong side of the operating table. The most important risk factor is the surgeon, but it doesn't never happen or is never present in any of these analyses. So, having said that, there is another problem. This is an old slide which I presented before. We as surgeons tend to be a bit arrogant. We think we are more important than we are, and we are not very good at looking at the evidence. And in this respect, I would like to show you something which has been published in what you would call a rather obscure journal, the New Zealand Journal of Surgery. This was a survey, including also cardiac surgeons, where they were asked virtually, what is your attitude towards evidence-based medicine? And they said, great, this is fantastic. However, they concluded, and this was almost unanimous, not using evidence-based medicine does not adversely affect their clinical decision-making. And they have higher confidence in their own judgment compared with low confidence in clinical practice guideline, etc., etc., etc. Now, I don't think this is something which is quite rare. I think it's quite common amongst surgeons and certainly amongst our profession. Of course, then you have professional competition, and the professional competition is not just amongst ourselves, but as we heard this morning, where it comes to PCI and surgery, then it becomes even murkier. And why it becomes murkier is because there is a lot of money involved. So let's say I present you this situation here of a patient who's got a nice proximal LAD lesion and a right coronary. And of course, what is the evidence? I'm not sure what the evidence is, in fact, but the interventional cardiologist will say, I'll put 2 stents, you'll never see that patient again. And of course, somebody may say, oh, what about doing a left mammary artery through a mini thoracotomy, perhaps even using a robot, and then have an angioplasty on the other side? Or perhaps somebody say, and I would be one of those, what about putting a couple of mammary, one on the right and one on the left? But as you can see, it's a completely different view. I just offer you 3 views which would be very difficult to dispute which one is better than the other. And of course, in all of this, you have to take into account, as I said, financial interest, which is not only the personal financial interest, but the fact that most of the randomized study, particularly the one between angioplasty and surgery, are virtually all sponsored by the industry, which is about 10 billion euro per year. In my country, for this money, somebody will shoot you on the knees if you don't agree. So there is obviously an element of conflict of interest in all of this. But perhaps the most important things, in my view, where we should look introspectively to ourselves is complacency. There is no question that we have made enormous stride in the last 30 years. Mortality has gone from 25% when I was training as a registrar in coronary surgery to 1 or 2%. Until recently, we had so many patients and we didn't know when to operate. We had waiting lists of 16 months. And this, as a consequence of this made us very complacent. There was not really much of an incentive of doing anything new or changing anything as such. And this is my last slide. In the last 2 years, I've been working on and off, also at Imperial College at the Hammersmith. And it was interesting going in a library and other place, how I really had the opportunity to see what this place had done over the years. In the late 60s and 70s, it was like the center of the universe for cardiac surgery. They were developing heart-lung machine, myocardial protection technique. You know about the Bono operation. What I would like to ask in the last 15 years in terms of innovation, I think probably not very much. We've been standing still where other people, our discipline, have moved much faster. And this, in a way, is often what leads to polarizations. There's no point in arguing if it's better on pump and off pump. Off pump may be better in my hand, but not better in somebody else's hand. I think the real question is, and I'm sorry to paraphrase Darwin here, it's not the fit, intelligent and cardiac surgeon, I think, are neither of these, but it's the one who adapts faster. I'm afraid I think we have